Yeah, I'm Lisa Brown. I'm the genetic counselor for the Cancer Center. And I specialize in hereditary cancer. So the majority of my talk is going to be about hereditary cancer genetic testing. However, I'm also going to cover some other types of testing and also the causes of cancer in general. Because the majority of cancer is not hereditary, right? We'll talk about that. So the causes of cancer, things you can do to prevent or detect cancer early, all that kind of good stuff. Before I start, how many of you have ever had genetic testing? Just raise your hand. Have had genetic testing? All right, so a smattering. Yep, we're going to talk about that. And how many have ever seen or know what a genetic counselor is or does? Okay. So that's the first slide, right? Is just what we do. So first and foremost, we are genetics experts. And what we do is we help patients and physicians negotiate the complexities of genetic testing. Physicians have a lot of other things to think about, and so they come to us for guidance and expertise on small details. And families, what we do with them is help you understand, right, genetic risks based on your family history, help develop, enable you to make informed decisions about whether you want to have genetic testing. What is the genetic testing? You need to know that before you do genetic testing. One of my most important jobs is explaining the test results to patients, especially when they're positive. I'm involved in making sure the patient has a doctor to go to that knows what the next steps need to be, so that you and your doctor can make the best plan for moving forward. And another really important job is to connect you to resources. Because genetics is a journey, right? You're going to be learning more and more about genetics as we learn more. And so having resources to do that are reputable are really helpful for you. So I'm going to get basic, just briefly, what is a gene? We have 23 pairs of chromosomes, right? We get one from mom and one from dad. That's why they're pairs. And on the chromosomes are the genes. And the genes basically contain the instructions for the proteins. And the proteins have specific jobs that help your body work normally, is basically so the genes are the instructions. So hereditary cancer predisposition genes, they carry instructions that make proteins that suppress cancer growth, right? Suppress cell growth. When damaged, these genes can increase the risk to develop certain cancer types, tumors, even polyps in their lifetime. So the goal of genetic testing is to improve outcomes with proven medical interventions and screening. And we'll talk more about that in a little bit. But each gene, the management is based on each gene. And I'll talk more about that later. So another thing, getting back to basics, is I already said most of us are born with 2 chromosomes, 2 working copies of every gene, right? One from each parent. This means a person with a gene mutation is born with a damaged copy and a normal copy of the gene. So therefore, their children have a 50-50 chance, right, of inheriting the damaged copy or the normal copy. And so genetics is a family affair. To me, people understand genetic testing better if we demystify it, right? If you know exactly what it is that we're looking for. So with this picture, these letters underneath are basically the genetic code. I liken it to the alphabet, right? We have a 26-letter alphabet. We have a 4-letter alphabet for genes. Genes are thousands of letters long. So in order to keep track of all the letters, we number them. So that's where the 120 and the 130 is. Those are specific areas on the gene that are important, or not important, but they're part of the instructions for the protein. So when you get a test result, it looks kind of weird because it'll say you have a genetic mutation. But what is that? It's basically a spelling error. If you look at this BRCA1, we're going to talk about BRCA1 in a minute, but at location 724 of the BRCA1 gene, there's supposed to be a letter C. So you can equate that with like spelling the word color, right? The gene is spelled correctly if there is a C in that location. So a spelling error is if the C was changed to an A. That's a spelling error. It's kind of like dropping the vowels in the word color, right? It's a spelling error. What that does to the protein is it changes the corresponding amino acid. So normally at that location, there's an amino acid called an R gene. Amino acids are the building blocks of proteins. And instead of the R gene, there's a serine there instead. So that's it. I mean, I know this doesn't look that much different than this, right? But this is normal spelling and this is an error. So it's just basically a spelling error. So what it looks like in picture format, because I think this is a little bit more understandable, is this is a normal gene, and then this is the mutated gene. It actually causes a protein to be damaged. So, for example, hereditary cancer predisposition genes, most of them are tumor suppressor genes, like I said. So this means that whatever cell this gene or protein is functioning in can grow out of control now and potentially turn into a large tumor or cancer. How many people have heard about Angelina Jolie and her journey with the BRCA1 mutation? She had a mutation in the BRCA1 gene. As I already said, it's a tumor suppressor gene. Because of that mutation that was identified in that gene, it did increase her risks to develop, lots of different cancers. And that's what I mean by the management depends on what gene is mutated. There are other genes that increase the risk for other cancers. And we'll talk about it a little bit later. But basically, this increased her risk. She was considered a pre-viver, right? So people get genetic testing because they have cancer and they want to know what caused it. And then they get testing because a family member had cancer and they want to know what caused it and if they're at risk. And so she was a pre-viver. So she got genetic testing and it allowed her to make decisions about her care. And so these are all viable options, but screening, you can detect cancer early by screening using mammogram and a procedure called a breast MRI. Ovarian, I won't go into that much because there's really no good screening tools for that, but it's a perfectly viable option for patients to choose screening. However, Angelina chose risk reduction. So she chose surgery. This next slide kind of shows what that did for her. So by having a mastectomy, it reduced her risk by greater than 90% to develop breast cancer. The screening doesn't prevent you from developing the cancer, but what it does is it helps you identify the cancer at an early stage. So it's not life-threatening, hopefully. The oophorectomy is, can't really see this very well. There's also like a white, at least I can't see it from this angle, but oophorectomy, the dark blue affects breast, and then the light affects ovarian. And so removing your ovaries reduces your risk by up to 96%. Some people ask me, why isn't it 100 for either? And that is, there's other cells in your abdomen that are related to your ovaries. And you cannot remove all of your breast tissue kind of for the same reason. So that's why these risks aren't 100%. And there are other things that you can do to prevent cancer from developing. So we've been talking about what I call germline testing, which is the little stick figure on the right. That's where we're looking for a genetic change, in all the cells in our body. I'm going to talk a little bit later about somatic testing, because you may hear about that as well. And the kind of testing I do is diagnostic. So, and that's going to be compared to what we're going to talk about the other kind of tests. So diagnostic tests read the entire sequence of the gene. They look at every single letter. They even do specific other tests, like looking for big deletions or extra bits of DNA in there to see if the instructions are bad that way, because it's not always picked up by sequencing. So it finds the key is it finds rare variants. We do it nowadays by panel testing. This is not all the genes that we test for, but we do test BRCA1 and BRCA2 are on the top of this list. You can see we can test for lots of hereditary cancer predisposition genes and all these different cancer types: breast, ovarian, colorectal, endometrial, and so on. One thing that my patients really are thankful for understanding is that not all hereditary cancer is high risk. So we've just been talking about the BRCA1 and BRCA2 genes. Those are high-risk genes, right? They increase your risk for breast cancer 40 to 60, 80%. There's other genes that we test for now that don't increase your risk that high. So when people are waiting for a test result, mostly the people who don't have cancer but are wondering what caused the cancer in the family, I make sure to tell them that a positive result isn't necessarily bad information. One, you may not have a high-risk gene, and the management for moderate risk genes are, and it says here, 20% or higher versus 40% or higher with high risk, is a lot different. Your risk to have breast cancer, let's say the moderate risk gene is 20% compared to the general population of 12%. But think about what your risk is not to develop cancer, even though you have that genetic mutation. So I love this graph, and this does help a lot of my patients understand this concept. These are the 8 genes that we test for hereditary breast cancer. It shows you here what the actual risks are. So BRCA1, BRCA2, and PALB2 are kind of at the top here. So they are high risk. This is a study of over 100,000 women. So this is actual data. The moderate risk genes are more down here, closer to the general population risk. So we're going to manage people differently because their risks are different, right? And so this may be a little bit overkill, but this may not be the only cause of the cancer in the family because it is such a low risk. There might be other genes that we haven't yet discovered or are weaker. And I'm going to talk about that concept of multifactorial in a minute. But this slide usually brings a lot of comfort to people, especially when I'm talking to somebody who has a moderate risk gene, right? To help explain how that is affecting their risk. Another big part of my job is what I call cascade testing, but basically it's when we identify a genetic, a pathogenic variant is the same as a mutation, in the first time in the family, we want to test as many people in the family as possible. So the next step is to tell family members. Now that can be super difficult. I talk to a lot of families that will tell me, well, I'm not in contact with so-and-so, or I'm estranged or this or that. And I just, it's up to them whether they pass the information on or not. However, you could save a life by passing this information on. Let's say you haven't talked to, Aunt Joe in like 20 years, but by sending her a small note that I supply, I basically give you a note that says you can give to them that explains what this is, that they could get testing to prevent cancer or detect cancer early. Nowadays with Facebook and all this other things, tends to be a little bit easier to find those cousins in Ohio or, something like that. So I try to encourage people to actually reach out, even though it can be uncomfortable. And the other thing that, if you're going to learn anything from this lecture, one thing is that it may feel awkward, but you need to share a copy of your test results with them. Remember that C dot, P dot, the spelling error? They need that so that their doctors can confirm that they have the exact change, that to make sure they're getting the correct testing, and to make sure that they have that exact change or don't. It's more important for people in the family who don't have, because if I don't see a copy of a test result, a positive test result for a relative, I can't say for sure that the person sitting in front of me is truly negative. And that's because genetic testing has limitations. And that's a hard thing for people to understand. They think, oh, genetic testing is just genetic testing. And if it's negative, it's negative. Well, there's different labs, right? There's different tests. And so things can fall through the cracks. So it is super important to send people a copy of their test results, but it's hard to understand. Some people feel it's an invasion of privacy, but that is something that I do a lot of educating on. So a question, you guys probably know the answer, but can genetic testing, or does genetic testing tell you if you have cancer? Any yes, no? Some people think that, I get the question all the time, does this mean I have cancer? And the answer is, fortunately, no. And this is a really busy slide, but it really does explain the difference between hereditary cancer and sporadic cancer, and why it doesn't cause cancer, but increases your risk. So I have this, that most of us are born with 2 normal copies. Hereditary cancer, you have a damaged gene in all the cells in your body. So you still have another normal copy. So that's why you're not born with cancer, because you still have this other copy of the gene that's functioning properly. But over time, environment does make a difference in hereditary cancer to some extent. Aging, though, is the biggest environmental risk factor for cancer, and one of the biggest, because people develop cancer when they have a hereditary cancer mutation because that second copy gets knocked out somehow. So it takes time for that to happen. Most cancer, you're born with 2 normal copies of your genes. And it takes time to develop not just 1, but 2 damaged copies in 1 cell. And that's what the cancer grows from. So that's the answer to that question. So the other types of testing are going to be more things that you may be exposed to, even more than hereditary cancer testing. So this slide, I showed you the germline side, right? But somatic testing is when they just test the tumor cells. So that previous slide, I basically said, you know, the tumor is picking up mutations that weren't originally in your germline. And so that is what somatic testing is doing. But it's extremely helpful. What we do is we get a piece of the tumor. Germline testing, we're getting a blood test or saliva test. And this is basically what personalized medicine is called. You may have heard of family members who've had some kind of a genetic change. Well, that's not an inherited change, right? That's a change, that's how their tumor is functioning and acting. And so that is why they're eligible for certain treatments based on the genetics of the tumor. And a lot of people get confused by this, so which is why I wanted to bring it up. So 23andMe, right? More people probably have gotten tested by 23andMe. So I wanted to explain to you how that's different than diagnostic testing that I do. So 23andMe is genotyping. It's not sequencing. So basically, we're not looking at the entire sequence of the gene. We're just looking at a SNP here and a SNP there, they call it. So these changes are not even necessarily in a gene, but they've just done these studies that track that change in lots of people with a certain health condition. So it's not diagnostic. It's diagnostic means we can tell you for sure that if you have a moderate risk or high risk gene, this is what your risks will be. With these, you can't really say what your risks will be because there are so many other factors that play a role in a person developing that particular disease. So this is a picture of how this is different. So hereditary cancer testing looks for rare variants. Genotyping looks for common variants. But the risks, look at the risks for rare variants are higher. The risks for common variants tend to be lower. Some people choose not to do what I call direct-to-consumer testing, DTC or 23andMe, because they're afraid that their, data, somebody will buy their data, send it, share it with other people, and there's a risk to that. And it is a valid concern for direct-to-consumer testing because there's no regulation on those companies. So if you trust a company and they have a policy that says, this is what we do with our data, then, that's how you make a decision whether you want to go ahead with that testing or not. but it's not something that's uniform, that they can't, whereas diagnostic testing falls in the green section. It's covered by HIPAA, it's covered by another law called GINA, and these entities, there's protection. So some people come in and say they don't want genetic testing because they don't want us to share their information, but that's not diagnostic testing. That's the 23andMe and Ancestry and other testing. And so I said in the beginning, hereditary cancer is rare. So I just wanted to finish up by talking about all the other ways that cancer is caused. One of them, we've kind of talked about sporadic a little bit. Hereditary is the 5 to 10% of cancer. 15 to 25% is that familial multifactorial that I was talking about. There's more people with familial cancer than there are hereditary, and there's more people with sporadic cancer than there are familial or hereditary. And so it's basically multifactorial. It's only when genetic factors overlap with environmental factors that weaker genes, right? They can't alone cause the risk, but if they team up with other genetic changes, they can increase the risk enough to put you over a threshold to develop cancer, but it's a lot more complicated. There's no genetic testing for that. So a lot of times when I test people, they don't have a genetic test, but they have they don't have a mutation, but they have a family history of cancer. So they get lumped into this 15 to 25% familial category. They still have an increased risk based on their family history. They still may need increased screening, and there are actually guidelines out there that say if you have a close relative with colon cancer, you should be getting colonoscopies starting at age 40 every 5 years instead of every 10 years. So there's lots of ways we can make recommendations to detect cancer earlier, prevent cancer, whether you have a genetic mutation or not, based on your family history. So what can you do? We talked about environment, lifestyle, radiation, all those kind of things. There are tools like the American Cancer Society, and that you can look up what screening you should be getting at what age, even in the general population, because cancer happens in the general population. You can, learn more about your cancer risk by going to these resources. There's so much out there. UF-IFAS has a module, the Take Control UF, that you can go through these modules to learn how you can reduce your cancer risk. Family history is the key, is not the key, but it is a big role. And when I collect family histories, a lot of people don't know what age their relative was diagnosed with cancer, or even, what type. And so it's helpful for you and your doctors to manage your cancer risk. If you know that, your aunt was diagnosed with breast cancer at 45 instead of 75. So educating yourself, asking those questions if people in your family are willing to share, making a document for the whole family, share it with the family. Say, hey, I'm calling you up because I need this, but once I'm done, I'll share it with everybody. This alone could get you increased surveillance. People who do not have a hereditary cancer gene, but have a family history of breast cancer may be eligible for increased screening just based on their family history. But you need to know the ages of diagnosis and the types of cancer as much as possible. I like to know whether it's spread or not. whether they died from it or whether they lived a long life. But ages of diagnosis and types of cancer are really helpful. And this is just, there are genetic testing criteria out there. I haven't updated this slide in a few years, but it's very similar. Not everybody is eligible for genetic testing. There is diagnostic hereditary cancer genetic testing available as direct to consumer. But you still need a doctor to order it, but the lab kind of helps you do that. And that is something I recommend that you go through your doctor or a genetic professional, but I'm not going to not tell you that you can do it on your own. And depending on if you're a healthcare provider, a lot, you may choose to go the direct-to-consumer route. But just keep an eye on your family history and know and ask questions.